Hello, everyone. Thank you for joining us for our presentation and discussion about the People's Applied Research Center. I'm going to share my screen and let's see here. And I think we're in good shape. So we're going to be talking about, some people know it at LMU as the Psychology Applied Research Center. We're actually looking forward to changing or altering the name from the Psychology Applied Research Center to the People's Applied Research Center. And what we're going to do today is, with our little team, is share a little bit about what we do and how we do it and how it seems to make a difference in the community. So let me start with a little bit of grounding and explanation about our origins. So PARC at LMU really does operate from the position of community-based participatory practice, which means that for us, social justice ethos is the grounding of our work. We do with and not for communities. Culture, history, context, and things like politics and economics matter. Flexibility, use of mixed methods, and privileging indigenous knowledge is essential to the work being meaningful. And we are guided by the wisdom of the community. So we actually want to kind of get your sense of a few things, and we're going to start with some polling questions. And so if you will join us, we're going to do 4 polling questions at one time, and then we'll talk about the results later. So I believe you can see the first question, which is PARC's research approach was most influenced by principles and tools of empirical research, theories from social psych and sociology, community residents, the media like print and TV news, or political science. What do you think? And I'm not seeing anybody actually able to vote. So I'm not sure, Stephanie, if for our webinar, people are able to indicate. So if you can't, no worries, just write down your answer for question number 1. And we'll consider it A, B, C, D, and E. So A is the principles and tools, B, the theories, C, the community residents, D, media and print, and E, political science. Question number 2. Which of these businesses poses the greatest threat to historically marginalized communities of color? A, liquor stores, B, smoke shops, C, marijuana dispensaries, D, all of the above. So jot down what you think the answer is. 3, which of the following is a prescription drug? A, birth control, B, penicillin. Uh-oh, I don't know what happened there. Okay, B, penicillin, C, Valium, D, Viagra, or E, all of the above. Okay. And then the fourth and final question, which of the following built a sense of community and contributed to well-being in Skid Row, right here in downtown Los Angeles? A mental health center, B, a health clinic, C, a place to shower, or D, shelters? Okay, so now we're seeing somebody was able to actually vote. Oh, okay, so the voting is now coming through. Okay. And I'll give folks a few more minutes to give their answers. It looks like it's still only a few people who are actually able to vote. So to not take away from time, because we've got a lot we want to share, I will go ahead and reveal the answers as we go along. All right, okay. So I'm ending the poll and I'm ending that. All right, so here we go. The answer to this will become apparent in just a second for the first poll question, okay? So, essential to our work is this notion of humility. And true humility is staying teachable regardless of how much you already know. And that's especially a message for academics, for researchers, for scholars, because we think that we come into a space equipped with a knowledge base and a set of expertise and tools that really should lead some work. And we found that that is actually not the most productive way to do work in applied research and work that is engaging the community. Unfortunately, what we do is that in health and mental health, we privilege the Western Eurocentric perspective. And that actually short circuits our ability to gain new knowledge. So we actually operate from a community-based participatory practice research model. Why? Because it's a door to cultural humility. We are not the experts. It's those with the lived experience that are the true experts. And from them we learn. So the answer to that first question is who most informed our work? It was and is the community residents. Our origins were from going in as PhDs like myself to becoming folks with WMD degrees. And we got that degree from the Communiversity of South Central Los Angeles. And I know you're like, what is a WMD degree? It's a what matters degree. And it's not all the initials after our name and all those theories and those standardized tests that we learned and developed. It's what matters to the community degree. So what if we then privilege in our work the perspectives of the community, not just in terms of research, but in the development of interventions and the assessment of outcomes? We would actually find, as we have in applied action research, that when you let the community lead, when you align and partner with folks who do community organizing, for example, that your research can have a much more meaningful effect because it is driven by and grounded in the wisdom and lived experience of the community, and it can lead to meaningful policy changes. And that has been the role that the Community Coalition, which was the kind of founding partner that helped us to develop our WMD degrees. And what we've learned in that process is things like history matter and politics matter. When the Community Coalition first started, we were very much immersed in the war on drugs. We had folks like Presidents Reagan and Bush really getting tough on drugs, and that really meant it was a war on poor people and people of color. The crack cocaine was fueling a major scare across the country, and people with a health problem were actually turned into criminals. We also learned that social conditions mattered, right? And so things like the liquor stores and crack and crime and community disinvestment were challenging the heart and soul of South LA. And so in those early years, as we were earning our degree, the foundational years were from December of 1990 to 1994. And that was a time of considerable social upheaval and unrest. And what we found was that in interviews with, in surveys with the community at people's front doors, was that folks were worried about the crack crisis, but we said, wait, let's make sure. And so we did a massive community survey going door to door to get the pulse of the community. And what we found was that when you ask the community, your assumptions are actually exposed for either their validity or their lack of validity. And in this instance, we were headed down the path of addressing crack cocaine, and the community said, no, it's the liquor stores. And that then supported the community to hold accountability sessions with the county, with the city, with the state, aided by community-based participatory research. And so the University of South LA taught us, respond to the moment, be where the community is at, not what your theories in psychology or sociology or et cetera are telling you, not what your research trajectory is telling you, but what the community is telling you. And so that led to the first major campaign that was launched in August of 1991. And I'm building up to introducing Dr. Ray. But the crack cocaine, yes, was an issue, but the liquor stores were an even greater issue. And so that led to this campaign, but the campaign had to pivot quickly. Why? Because not far after we launched came the 1992 uprising. And the community was clear that they did not want to rebuild with all of these liquor stores. And in a matter of a couple of weeks, over 35,000 petitions were signed in South LA to not rebuild with liquor stores. And that campaign led to preventing 150 outlets that were burned out to not rebuild. It led to the conversion of 44 liquor outlets. It helped the community coalition to become a powerful voice and actually advocate for health promoting public policy. It also helped, it also helped to shift the public narrative, because we continued to check the pulse of the community to inform the community organizing campaigns that the coalition was engaging in. And one of those campaigns was around the conditions and the experiences and the well-being of youth in the 7 South LA high schools. So when research policy follows the community's lead, policy wins can happen. And so this is just one example with the substance abuse in the liquor stores. In education, we were able to achieve all of these different education reforms. And in drug prevention and in relapse prevention, not relapse prevention, reentry, and recidivism when it comes to incarceration, we were able to achieve these policy wins. And in the child welfare system, we were able to achieve a series of wins. So the coalition went from wanting to be at the table to convening the table, building youth and adult power, supported by research that was guided by the community's agenda. This is action research. And emerging issues continued when we kept checking the pulse of the community. And so what did we find? Smoke shops and marijuana dispensaries, based on some community mapping that we did with the help of two of our postdocs, led to the beginning formulation of a new sense about what were some of the greatest threats to the community. And so the academic or scholarship side of research can work side by side with the community-based research. And so we've been publishing things like this article to explain and to share with folks, when you let the community lead, here are some of the things that you will find out. So that work and that paper actually then led to a tobacco control grant that we are currently still working on to reduce tobacco-related health disparities. Our focus is that research can contribute to community organizing, which can contribute to public policy, which can impact what we call the trifecta. And now I'd like to introduce Dr. Peter Ray, who is an anthropologist on our team. And yes, I want to also slide in there this notion that even though we are housed in the psych department, we are very much an interdisciplinary team. We feel that we cannot do this work solely with the lens of psychology. So he is going to share with us some information about the co-location of liquor stores, marijuana dispensaries, and smoke shops in the trifecta hotspot. So you remember his question, which is, which of these poses the greatest threat? So let's see if your answer aligns with what Dr. Ray is going to share. So I'm going to turn screen share over to you, Peter.
Thank you, Dr. Grills. And thank everybody who is in attendance today. So as the question that I posed asked, which of the following was the greatest threat to historically marginalized communities of color in South Los Angeles? The options were liquor stores, smoke shops, marijuana dispensaries, and all of the above. And for those of you who answered D, all of the above, you are right in a sense. But the fact is that it's a bit more nuanced than each of these properties having an independent effect on communities of color, on communities like South Los Angeles. Instead, they have what we refer to as the trifecta effect, where it's a combined effect that these three are in tandem having. And this is because smoke shops and dispensaries tend to co-locate next to liquor stores, which have a long-standing relationship with the community. So in my talk today, I want to focus on the following items. First, I want to describe the context that has led to the oversaturation of liquor stores, smoke shops, and marijuana dispensaries in South LA. I'm going to do a little bit of an abbreviated version than I originally planned, just because Dr. Grills did such an amazing job kind of setting it up and teeing it up for me. I'll then go ahead and provide a little bit more information on the trifecta, as well as the effect that it has on South LA. I'll then describe our role in the tobacco-related disease research project, which we refer to as TRDRP collectively. All the while, I'll be uplifting the role that our partners and colleagues at Community Coalition have played throughout this entire process. Uh-oh, it's not letting me advance my slide. Just a second, I'm gonna stop sharing and then reshare. Crap. Okay, excellent. So as Dr. Grills outlined, the relationship between liquor stores and the community in South LA has been rather tumultuous over the years, especially in the aftermath of the 1992 uprising, but also following the destruction of a number of these liquor stores. It provided Community Coalition with the opportunity to prevent the reopening of these stores in the community, as well as allowing them to shut down another 150 odd stores following the 1992 uprising, and which is like a monumental win. And despite this massive win, the problem of liquor stores still pose a great threat to the community. And it's not just the liquor stores that are a perceived problem. As Dr. Groh was mentioning, it's the smoke shops, it's the dispensaries that are co-locating all around the liquor stores that are providing a combined threat to the community, which is as evidenced by that poll that Dr. Groh mentioned of the 7 local high schools in South LA. So as I mentioned, what we have here is a collective problem that we refer to as the trifecta. And at the heart of the trifecta are these magnet liquor stores, which are indeed drawing in the other nuisance businesses to co-locate near it. And this is because these liquor stores have this 30, 40-year long-standing historical relationship with the community. They have a long-standing customer base, and these other businesses are getting in there trying to draw customers from the liquor store to have them frequent their stores instead. So that's why these dispensaries and smoke shops are tending to open up in the area immediately around these magnet liquor stores, right? And as you drive down some of the main drags in South LA, these trifectas are apparent, these trifecta hotspots, right? You'll see liquor store on one corner, right across the street, there's a smoke shop, caddy corner to that, you'll see a dispensary, and it's all throughout South LA. And while smoke shops maybe are opening and closing every couple of years, dispensaries being even more kind of transient in nature, the one constant that is present in the community are these liquor stores. And together, these businesses pose what we refer to as the trifecta effect on the community, which basically indicates that increased density of these trifecta hotspots are leading to more crime and violence, as well as increased exposure to drugs, which in turn are going to subsequently lead to poorer health. Furthermore, the presence at such a high volume of these businesses provides less opportunity for and less space for healthier community assets to open up instead of the trifecta hotspots. Okay. So here is a map that demonstrates the widespread nature of these magnet liquor stores in South LA. So this map pulls data from 2019, and it kind of shows that these magnet liquor stores are basically on every major corner throughout the community. Next, when we went ahead and we mapped all of the smoke shops and dispensaries, we basically are demonstrating that the trifecta effect is indeed in full effect, with these smoke shops and dispensaries co-locating next to the liquor stores, right? We see smoke shops on top of dispensaries, on top of liquor stores, and all congregating around these magnets. Now, when you compare those maps to the situation in West LA, where there's only 1.97 or roughly 2 liquor stores per square mile, the contrast is pretty stark. Furthermore, there's basically little to no trifecta effect once we map the dispensary and smoke shop data from West LA, just further magnifying the fact that there's real inequity in the density of these properties. Okay, so was this inequity and the intimate role that smoke shops play in the trifecta, which was uplifted in our survey of South LA youth that led for PARC, COCO, and resident leaders in South LA to apply for a research grant within the state of California's Tobacco-Related Disease Research Project, or TRDRP. Now, taking direct input from the community, our role in the project focuses on 3 aims that revolve around the trifecta. The first 2 kind of honing in on the relationship between density and community health, as well as trifecta density and proximity to youth spaces. And then the third aim, which I'll focus predominantly on for the second part of my presentation here, just in the interest of time, that focuses on the effectiveness of community coalitions, policy campaigns, and their influence on LA City and LA County policy around these trifecta hotspots. So a little bit of background on these campaigns. They were requested initially by members of the South LA community, as well as local policymakers at LA City Council District 8, to advance their ability to understand and implement science-informed policies around controlling alcohol, tobacco, and marijuana. And as far as our initial goals around this third aim of TRDRP, we originally wanted to collect and analyze data around the community organizing process and outcomes, as well as on the major policy wins that Community Coalition had. And we're going to do this through annual semi-structured interviews with coalition staff, as well as some monthly direct observations and hearings. In addition to that, we also have recently, through our partnership, developed a mixed methods tool, so a qualitative tool, to collect actual to collect data around these hotspots. And so far, things have been fairly productive, very productive, if I may say so. For example, in 2019, COCO, in collaboration with a number of other grassroots organizations from around LA County, fought for and won a county-wide ban on flavored tobacco, which went into effect in May 1st, or on May 1st, 2020, in unincorporated areas of LA County. So currently, Community Coalition and partners are working to push this through at the LA City level next. COCO has also been able to make gains in combating problematic liquor stores, or further gains in combating problematic liquor stores in South Los Angeles. Of particular note is the case of Monarch Liquor, which is located on the corner of Vermont and 88th Street. Monarch had long been highlighted as it being problematic to the community, and this was backed up by the violent crime statistics, which listed the area as having one of the highest homicide rates in the county. When COCO interviewed local residents, they of course confirmed Monarch to be, a big problem, but they also stressed that they wish that it could be converted into a grocery store to offer the community fresh food options. And so while COCO was able to mobilize, collect data and information that was needed to shut down Monarch, and indeed got their license revoked, they also encouraged Monarch's owner not to sell up, to stay in the community, and instead actually supported her in her conversion of Monarch Liquor into a grocery store that would provide these needed assets to the community, which she did in early 2020. And this photo here actually shows the active rebranding of Monarch Liquor into Monarch Market, which actually turned out to be a real godsend to the community, having this asset local during the pandemic, where they have a nearby, steady, consistent source of fresh food. Okay. So while the county's ban on flavored tobacco and the success with Monarch were some of the year one benchmarks, the current focus of AIM-3 is the development and implementation of the environmental scan tool, which was, as I mentioned earlier, was developed collaboratively with COCO, PARC, City Council District 8, and South LA residents, with the idea of it being able to be used as a tool in future hearings, such as the hearing with Monarch. The environmental scan itself scans trifecta hotspots in 3 different domains. Those domains being neighborhood environment, compliance and property conditions, as well as business marketing practices that are being used by the trifecta businesses, as well as the alcohol, tobacco, and food products that they're selling. Furthermore, this environmental scan tool gives us an opportunity for some political education with residents in the community, as we're actually developing a measure which we're going to use to kind of track changes in residents' political consciousness around these particular items. So seeing if their perception of the problem revolving around liquor stores is being shifted to the problem being, more around these trifecta hotspots. Okay. So the way the scan works is that residents and CD8 or City Council District 8 collectively identify a target trifecta hotspot. COCO and PARC then do a social investigation to provide some context around the shop owners, right? What types of permits they have. And then we go out and actually do some geospatial mapping of the businesses to get an idea of what community assets may be compromised by the trifecta. And then after that, trained community residents go out and conduct the environmental scans. And since the summer, we've actually piloted the scan 3 times. And while I can't share everything that we saw, I will share some of the highlights. For example, in addition to seeing the dispensaries and smoke shops co-locating around these magnet liquor stores, we're also seeing the co-location of street sales, and that can be street sales potentially of marijuana, as well as blatant sex trafficking going around in the 100 to 200 feet radius around the liquor stores. We're also seeing multiple compliance violations. These range from alcohol sales to intoxicated individuals to alcohol being consumed on the premises. direct premises of the hotspot properties. We also collect information on place and space, kind of looking at which nearby community assets are being compromised. So for example, our smoke shops opening up next to, say, like a treatment facility that provides services to the community. We also are collecting information on where these hotspots are in relation to youth spaces. So are they on a frequent pathway that youth are going to be walking by the smoke shop, say on the way to and from school every day? And then again, we're also collecting information on the different marketing practices and the products that are being sold by these businesses. You know, for example, seeing information along the lines of targeted advertising and product placement for children. So like some of these shops are putting their brightly colored cigarillo wrappers like next to like the ice cream chest or next to some candy at the checkout. So pretty much like anyone who's going to be going into these liquor store smoke shops are going to be exposed to advertisements and tobacco products, even if they're going in there just to get some chips or some soda. Okay. Okay, good. So what are we going to do with this data? Again, the short-term goal is for COCO to be able to leverage these data in upcoming hearings so we can see some similar success stories like we did with Monarch. However, the long-term goal is focusing on the big picture, right? We want to be able to triangulate all aspects of TRDRP to bring about large-scale self-LAY changes. So these could be zoning restrictions that limit trifecta density, limit their proximity to schools, and basically by means of limiting these densities, we hope to improve the overall neighborhood health, which will be obviously reduce harmful exposures to different products, ads, all the crime, as well as provide equitable access to safe and healthy community spaces. Lastly, we want to inform other partnerships in the city, county, state, and beyond who are interested in making similar changes in their communities with the work and efforts that we're putting in on this project. So with that, I will stop sharing and I will kick it back to Dr. Grills.
Thank you, Peter. So I'm going to now introduce Dr. Diane Terry, and she is a research associate with PARC, and she's going to talk about our California Reducing Disparities project, looking at the topic culture and context in cross-site survey design and mental health practice. Dr. Terry.
All right, hello everyone. I'm going to talk about CRDP Phase 2. And as Dr. Grills mentioned, this is a mental health disparities initiative that's operating in California. And what it's looking at is 5 specific priority populations across the state that are specifically doing community-defined evidence projects. Those are projects and strategies that have proven to be credible over time within their specific communities in reducing mental health disparities. Our role as the statewide evaluator is to evaluate this whole initiative and also to really understand, you know, to what extent are these programs really effective in reducing mental health disparities within their respective communities. And as I'm sure you can tell, this is kind of right up our alley, this whole idea of really pushing back against very Western, narrow ways of framing mental health challenges, of framing inequities, and in really kind of uplifting community voice in the process. So it's a perfect fit for our research lab. Go to the next slide. So there's many, many measures in this initiative. It could take hours to explain. So I'm going to focus just now on how we've been able to develop a pre and post questionnaire. And the idea is that this is a questionnaire that would be administered across all 35 projects involved in the initiative. But as you can see right here, it's kind of complicated because these are not 35 projects that are all implementing the same type of program in the same type of way. Mental health services for one community might look like cultural celebrations, while for others it might look like support groups and healing circles, while other groups are just trying to help people navigate the mental health system and all of its complexities. So we're trying to implement a standardized pre and post in the middle of all of this. So there are some challenges there. You can go to the next slide. part of why it's challenging is not just because the groups themselves are so diverse, but it's also because everyone, the ecological framework in which all these programs are operating is also diverse. So we kind of have this first level, which is looking at just macro level. Who are all of the unserved and underserved and inappropriately served communities within these 5 priority populations: African American, Asian and Pacific Islander, Latinx, LGBTQ, and Native American. Then we have the meso level, which is now within each of those specific priority populations. There's so much diversity in terms of ethnic groups, in terms of age, in terms of language. So that's kind of, again, why it's hard to kind of implement this standardized approach when you're working with this much diversity. Then we'll add yet another layer, which is that even within these priority populations and within each of these ethnic groups, there's even greater diversity. So you have some groups who are working with justice-involved youth. You have groups who are working with elders. You have groups who are working with Muslim women. You have groups who are working with undocumented folks, transgender individuals. So it's a gamut of folks being served. And so at every step of this initiative, we have had to pause and think about what's the best way to represent community voice and cultural perspectives. You can go ahead. Those are all the diversity kind of reflected on the screen. So I think at this point, you're probably thinking, well, how do you kind of even implement anything that's participatory when you have that much diversity? And also when you kind of have some constraints. So I think a lot of times when we think about participatory research and evaluation and practices, we look all the way at the right side of the arrow, right? Something is participatory because there's shared decision making and there's communication and input, and the final product at the end represents something that every single person wanted. And that hasn't been the case in this initiative, but it doesn't mean we throw participatory practices out the window and say, oh, well, it's not happening. What we have been able to do specifically within the development of this questionnaire really falls at that level of involvement and also some collaboration when it came to developing the survey. That means that each and every step of this survey design, we've gotten community feedback. There's been participation from partners. There's been a lot of partnership on revising parts of the survey. What it's actually looked back has been numerous feedback sessions, grantee-wide convenings, Qualtrics surveys, everyone's favorite IRB. We have done 15 IRB amendments and counting. It's not over. So, and all of that has been done so that we could really make sure that we're centering community voice as much as possible in this project, even with the funding constraints and the specific research questions that we have to answer. So I'll give a couple examples of what that has looked like as we've developed the survey. So one of the big things that the survey has tried to get at on our pre-test is looking at mental health access, right? Where were folks getting help before they even came to some of these programs? What were barriers to getting help? And so as you can see here on the left, we had some items from the CHIS and from another national survey to try to get at what has help seeking looked like in the past 12 months before participants came to the door. But when we were in the early stages of kind of the community review process of this initiative and of this survey, you know, folks really stopped us and said, you know, it could be that people aren't going to their primary care physician if they're trying to get mental health supports. But what it could be is that they're actually using community resources. They're going to promotores, they're looking at peer counselors, social workers, they're going to culturally based healers or spiritual leaders, and that's where folks are getting help. So if you're really trying to understand mental health access across these very, very different communities, you have to incorporate those sources of help seeking in your survey. And so we did, and you can see on the right where we modified some of the items based on this community feedback that we got. Part of that included making sure that we included language about professionals when we referenced community-based sources of help. So we didn't want the idea to be that if you see a Western source of support, that's the professional, and then everyone else is just kind of community folks, right? We made sure to incorporate that professional language in both types of help so that folks could see that those are equally valued. So that was one of the first examples of how we really had to modify and kind of pivot and make sure we were incorporating community voice in the survey. The next big one came with some of our demographic items. So we had a set of 3 items that were specifically asking about gender identity, sex assigned at birth, and sexuality or sexual orientation. And so those items had actually been vetted and really kind of framed and developed by partners within the initiative. But when it came to some of the grantees within the API population, although there was really a big interest in asking these items, we had to stop to make sure, are we asking these items in the right way so that people across all different language groups, ethnic groups, SES levels are really, you know, is there equivalence of meaning when you kind of translate some of these terms? So for example, the idea about asking about gender identity, although you could translate the word gender identity into Hmong or Korean, it may not mean the same thing. So we had to really stop and say, okay, but our community partners helped develop these items. They're good. We should keep them as is. Or do we stop and say, no, because if we keep these items as is, there's going to be a whole cadre of participants who are providing answers, but they may not even know what we're really getting at. So is that data really meaningful and is it really valid? If you add onto there the layers of oral translation, folks who are monolingual, it kind of just further complicates what we think are very straightforward questions. So on the next slide, I'll show you how we modified some of these items. And this was in partnership with many of the API grantees, also with other partners within the initiative. And so here's one example of how we modified not just the survey language, but also the actual administration. So on the left, you see the original item is, when I was born, the person who delivered me thought I was and there's all these different response options. What we did on the right is we allowed staff to just administer it as an open-ended item. My sex at birth was. And what that did is it gave participants the opportunity to just provide that response in the language that they preferred and using kind of just the words that they preferred. Staff then translated those items and then checked the appropriate boxes. So what that did is it kind of allowed us to keep items we needed for the statewide evaluation, but to ask them in a way that made sense for those specific communities. It also meant for some groups just reordering the items, making sure that they were asking them that the flow of the survey items made sense. And then even for some groups, just to say, you know, we want to ask these over 2 sessions. We'd rather use that first session to kind of ask other survey questions. And then on the second time we meet with participants, then we'll follow up and ask about sexual orientation and gender identity. And so far that process has worked. We'll go on to the next slide. Another example of where we've really had to pause and think about community voice and kind of cultural representations had to do with items where we talked about psychological distress and functioning. Those are items that we had to include on the pre-test and post-test because we're trying to understand changes in mental health symptoms. But for some of the Native American grantees within the initiative, you know, they really had us pause and say, this is really at odds with how we frame mental health in our community. We don't tend to ask about what's wrong. We really tend to focus on what's right and how do we strengthen protective factors and cultural connectedness. And when we piloted this survey, you know, there were youth who actually felt distressed just as a result of taking the survey. So, you know, there was some push-pull there. We kind of went back and forth to say, how can we modify this and change this up in a way that's more relevant and meaningful? And in the end, we couldn't. And that's okay. What it meant was that perhaps those specific grantees may not be represented in the statewide evaluation, but it also meant that their community members didn't feel harm while taking the survey. And I think we would argue that that's more important than being represented in the statewide evaluation data. You can go on. Another example is just administering, allowing grantees and supporting them in administering the survey in the way that they wanted to. So because of IRB constraints, we were kind of told the survey has to look this way, it has to be given at this time point, there can't be any changes, so very, very standardized approach. And what we learned from several of our partners, again, 15 amendments in, folks have said, no, we cannot administer a survey in one sitting in this particular way. Most recently, there was a group who works with LGBTQ seniors, and their seniors very much wanted to participate in the statewide evaluation, but some had just had surgery, some were just physically unable to sit for the length of time that it took to take the survey. And so we advocated for that group to be able to stretch the pre-test across different sessions and the post-test as well, so that participants were comfortable and weren't being harmed in taking the survey. And then we also allowed their voices to be represented. And I'll give one last example before we close out, which is response scales. So we're all very, very familiar with the all of the time, most of the time, some of the time, and all these very kind of distinct categories. We had 3 grantees who told us very early on, these response categories are very, very difficult for our participants to understand. One group was actually doing like orally interpreting the survey as they were going along. So whereas in English, the survey was taking 15 to 20 minutes, for some of these groups, it was taking up to 2 hours. And so 2 modifications were made. One is that we allowed for this grantee to, or these group of grantees, to use a 3-point response scale. And statistically on our end, we're able to still incorporate that into the analysis. And then 2 of the groups took it even further by using and kind of inserting these visual cues into the response scale. So it's a 3-point response scale, but they also now have kind of a culturally relevant way for participants to be able to select their answers. We get the data, those perspectives are represented. So it was a real meeting in the middle there. Go on to the next slide. Strategies and lessons learned. I'll just keep it brief. You can show all of them on the screen. Really what it means and what we've learned along the way and really tried to uplift is that community has to be at the table when measures are being developed, when we're considering what are valid outcomes. It's hard, it makes things time consuming, and there is not always a perfect solution, but there's no way we can ever kind of push back against Western ways of knowing if we do not continue to make these pushes. And you can go on to the next slide, which is kind of hopefully where we're hoping to end at the end of this, which is that we really see this initiative as presenting an opportunity. We definitely see it as having its place in the social justice movement, so that people are collecting data that's meaningful and relevant for them and their community needs.
Thank you, Diane. And now we're going to hear from Dr. Sandra Villanueva, who's going to talk about data collection in the east side of LA, really lifting up cultural considerations in substance use disorders. And remember that poll question that asks about which of the following is a prescription drug. She'll reveal for you in a little while what the actual correct answer is.
Hi, good afternoon, everyone. I first wanted to start off with defining or giving some definitions to what is culture. It really emerges out of interpersonal realities. It's a dynamic relational process of shared meaning, and it must always be considered within a historical, social, political, and economic context. And some aspects of culture are visible. These are things like the environment, the places and spaces we inhabit, like the landscape and the architecture. It also includes a social setting, like our kin networks, behaviors such as the food we eat, the language, the dress, the rituals, and the practices that we all engage in. And this is what we typically think about when we're asked to articulate culture or measure culture. But there are aspects of culture that are invisible, yet they are so critical. These include norms, both shared spoken and unspoken expectations and rules that guide behavior and shape the environment. And at the core of culture are values and attitudes, and most importantly, those underlying assumptions and beliefs that guide everything else. So like that turquoise rectangle. Okay, keep going. So Dr. Shelley Harrell states, it is important to consider culture and how it influences an issue, a prevention strategy, and its evaluation. It provides the foundational frames for developing worldviews, interpreting reality, and acting in the world. When it comes to substance use disorders, one must consider both cultural and societal factors, stressors, and barriers. And I want to kind of hone in on the mid-level and the bottom level, because prevention and intervention strategies are all shaped by culture. And most of the time it's rooted in US Western culture and research. But we can't forget that it's also rooted in the community's social position and power due to ethnicity, race, and class. So structural racism, including inequitable public policies, contribute to health disparities and social disadvantages for BIPOC communities, especially when it comes to resolving substance abuse or substance use problems. And there continues to be a lack of culturally focused prevention models that are contextually specific and tailored for communities of color. All right, keep going. Today, we're going to focus in on the role of research and culture in understanding prescription and over-the-counter meds, use and misuse in LA County. This was a 2-year massive effort that involved various stakeholders across the county, but most importantly, it involved a network of 51 community-based prevention agencies. And they were unified in their mission to identify what the RX and OTC problems and behaviors were across the county, assess risk and protective factors, and identify and bridge data gaps. So they know what the national data was saying about RX and OTC drugs and meds, but they did not know if they could confirm that at the local level in LA County. They were able to collect over 10,000 surveys in a 1-year period. One of the 51 community prevention agencies was the Community Centered Emergency Room Project, or CCERP. They're located in Boyle Heights neighborhood in the east side of LA. While they were also deeply involved in the countywide effort, they wanted to do a simultaneous community-driven qualitative data gathering process. And as their local evaluator, we couldn't wait to jump in and help them out with that. Cheryl, you can press enter. Their CBR data collection process was led by Latinx residents, and it involved a series of focus groups in Spanish to assess culture and context in the exact same areas that the county needs assessment was doing. They wanted to use both sets of findings to design culturally responsive RX and OTC prevention strategies for Boyle Heights. Both efforts use CBPR in very different ways, and the findings both were meaningful, yet very, very different. And so we can move on to the next slide. So a finding from the county's needs assessment in Boyle Heights was the following: a 12% misuse rate, which was lower than the countywide rate of 19%. So the findings suggested that prescription use and misuse in Boyle Heights isn't as high as in other areas in the county. However, some demographic differences were found: more males and females misused, more US born versus foreign born misuse. And the most alarming finding was among LGBTQ identified individuals who reported a 47% misuse rate. So you can already see how CCERP, this prevention agency in Boyle Heights, can use this data to design a set of targeted prevention efforts for their community, and that gender, sexual orientation, and immigration status should inform the strategies used for different members in their community. But they didn't stop there with just relying on the countywide needs assessment. They also had this qualitative assessment. So the countywide needs assessment effort was critical, again, with bridging those national data gaps at the local level. But in many ways, it's only half the story. So what did CCERP find? Context matters. Cultural beliefs and practices influence prescription med use and misuse. And this is the most important one: prescription misuse may actually be more of a concern than the countywide needs assessment revealed. There was 4 major themes that emerged. So one of the first ones that we found was that the Latinx community in Boyle Heights self-prescribe or share meds due to a lack of health insurance and access to affordable health care, including high cost of prescription drugs. So it's very typical to ask you to give your neighbor, oh, I have some leftover pills, and then they kind of just share because there's a sense of community, but also it's affordable and accessible. There's also very, very easy access to Mexican medication from local stores in Boyle Heights, or trips to and from Mexico that residents are more familiar with and comfortable taking. There's also this belief that Mexican medicine in general, including prescription drugs from Mexico, are more effective than US medicine. And last but not least, There's a lack of awareness and information of proper use and dangers about misuse. For example, not following dosage instructions as directed by a doctor or physician. And so on the next slide, I just wanted to uplift 3 quotes to highlight systemic barriers. The first one is, people sometimes don't even have money to go to a doctor's visit. Right now, it's more expensive to go to the appointment. The appointment is more expensive than the medicine they are going to give you. And that's why sometimes people don't go, because the truth is there's no way to go to a doctor, and it is easier to go and bring medicine from Mexico that you know. The next quote is an example of when we're talking about culture of environment and access. There's a local store here on Cesar Chavez. They're kind of known as botanicas. Some of them even have the word drugstore written in the front, and they sell Mexican medicine. They're very, very different than CVS. Some of them even have like a back waiting office area where traditional healers and or Mexican trained physicians provide services to the community. And then a last example of culture and fundamental assumptions and beliefs is, keep going, Cheryl. We grew up with Mexican parents and they don't believe in American medicine. They think that the Mexican medicine is more productive, more effective than the American medicine, which is nothing more than a syrup. It is sweet water. And Mexico's medicine is very effective within a day or two. And then last but not least, there's, again, Dr. Terry brought this up in her presentation. You can go to the next slide. That one of the major findings we found, one of the things we stumbled upon was that there was cultural misequivalence of meaning. So when we came back together to debrief on all the focus group findings, one of the things that we found out was that prescription and over-the-counter meant something different based on where you were from. So birth control, penicillin, Valium, Viagra are all considered prescription meds in the US, but they are all considered over-the-counter in Mexico. So if you were born in Mexico, and even if you're buying your medications in Mexico, you may not necessarily view them as needing a prescription from a physician or even needing to have supervision from a physician. So again, context matters, culture matters, and it also makes one wonder, what were people responding to in both the focus groups and the countywide needs assessment when we were posing questions around prescription drugs? So it's not just apples and oranges, it's apples and potato chips, because I love potato chips. And so this is just one little piece of data that CSERP is using in a long-term process that they've launched to help them develop and design culturally responsive prevention efforts, especially for community members that are most vulnerable to serious substance use disorders. And so that's it.
Thank you, Sandra. So I'm going to do this last example very, very quickly. And this one is a community designed, community managed project with a community defined evaluation study this is with the United Coalition East Prevention Project, which works on Skid Row. So remember that last polling question, which of these built the best sense of community and contributed to well-being? I think you'll find the answer to that very quickly. We are talking about what's called the Refresh Bot. It's a community-based participatory research and practice project where research coupled with intervention, coupled with public policy can move from a condition like this. This is a little area in Skid Row, and that same area transformed to what is now called the Refresh Bot. So Social Model Recovery Systems, which is the parent organization for USEP. USEP does the organizing arm of Social Model. They do drug treatment, drug prevention, and community organizing in Skid Row and in downtown Los Angeles. And for at least the last 20 or so years, you can find me with a clipboard walking side by side with the community, trying to gather the data to demonstrate the need, the issue, or the effectiveness. And so with the Refresh Bot, the problem was that in 2017, they did a public toilet audit, and Skid Row in LA didn't meet the United Nations standards for sanitation in a refugee camp. And so I won't go into detail, but there was a report that was done called No Place to Go, literally no place to go. And that has hygiene and health consequences, both physical health and mental health. So the Refresh Spot is community design for health and mental health promotion. It first opened in December of 2017 with a handful of toilets and showers, and it was only open 3 to 4 days a week. It became so popular that they closed it, did some modifications, and reopened so that it is now a 24/7, 365 operation, designed by the residents of Skid Row, staffed by advocates and unhoused residents of Skid Row. The security is not by LAPD or Sheriff's Department. They said that would cause problems. So it's by the Nation of Islam's Fruit of Islam. It promotes a sense of dignity, humanity, respect, and community. That was the goal, and they have achieved that. And they partnered with PARC to evaluate the effect. And so what we have, I labeled it the Cheers effect from the sitcom Cheers. Remember that song? And it really does feel like that Cheers bar without the alcohol, right? So let me just show you this quick clip from the news about the Refresh Spot.
After 6 months of expansion and improvements, people who are homeless in downtown finally have a place to freshen up again. Gil Reyes reports on the new and improved Refresh Spot on Skid Row.
To the relief of people in downtown, the only homeless hygiene center of its kind in the nation has reopened with new 24-hour showers, toilets, and laundry facilities. Skid Row's community Refresh Spot has returned.
I know in the middle of the night when it's hard to find somewhere to go to the restroom in downtown, it's really hard. I mean, when you have to go, you know, or taking a shower, you know, it's like, I mean, there's nothing. This place, I don't know what I would do without it.
After a 6-month delay, the center is definitely back better than ever. Back in December it opened, but then closed in March for what was supposed to be just a 1-month renovation. That dragged on. Part of the problem was ordering the new trailers that had to be shipped and plugged into local utilities. There was also a delay in receiving permissions from the state.
There were special customized trailers that were made to meet the needs of the community. And there were some challenges in getting them certified and getting them approved.
But Charles Porter from Skid Row's Social Model Recovery Systems says that's all in the past. Some 300 people a day now visit the center. There are 6 showers, 7 toilets, also 12 washer and dryers. Some of these facilities are wheelchair accessible.
The thing that I would stress is the importance of partnering with the local community to design it, to develop it, and to staff it, you know, because it really is a win-win. When you have people in your neighborhood that know what the issues are, give them opportunity to develop something.
Adeline Bertha wishes these free services were around when she was growing up, homeless, going to school, and feeling very out of place.
Having to have conversations with other people, and you know that you didn't take a shower, you didn't have time to brush your teeth, and the Refresh Spot gives you a feeling of community, gives you a feeling that there's other people who understand where you came from, and that your situation doesn't define you.
Goodwill, Homeless Healthcare LA, the Skid Row Community Improvement Coalition, and the LA Homeless Services Authority all partnered on the Refresh Spot project.
So one of the things I wanted to mention is I've said that it became really popular. It now averages around 17,000 visits a month. And that was with no advertising. When the community builds it, the people will come. And so if in answer to that question that I posed, it was the Refresh Spot. It was a place to go take a shower and wash your clothes that created not only a sense of community, but that also addressed and improved some sense of well-being, where people felt more refreshed, more comfortable, happier, inner peace, like a new person, confident, energized, less irritable, less angry, less self-conscious, a little less self-conscious. And what was really, really heartwarming was to see LMU students from various classes coming down to the refresh spot and helping out to get all those surveys collected to actually demonstrate the effectiveness of the refresh spot. And so now I'll turn it over to our discussant, Dr. Jennifer Abe. And I'll stop share.
Thank you, Cheryl, so much. We can't see you, but just, kudos to all of you for your presentations and for the inspiration that you offer us. I want to make sure we have at least time for a couple of questions. So I just want to lift up a few things. I imagine all of you are trying to absorb just the presentations, the quality, the density, the different perspectives. It was a very rich set of presentations that we've heard today. I think the renaming of PARC to the People's Applied Research Center, everyone would agree, is very much makes sense, because the work for combining community, methodology, expertise and making it a partnership is really something. And this is something that Dr. Grills and the team has been doing since, as Cheryl said, since the early 90s. And the reason why I'm a discussant in my role is I've been brought on different projects as part of their teams for all this time, and have seen firsthand the transformative work that it does, not just with communities, but with students at LMU and with faculty at LMU. And everything that I've learned from PARC, working with communities in this manner of community-based participatory practices, has influenced all the work that I do, as it has touched everyone who has been involved with PARC. So respect, dignity, valuing people and their experiences, valuing them as experts, and going to them in humility as experts of their own lives, and then working in partnership with them to create and think of interventions, to think of what does evidence mean from a community perspective? What are the desired outcomes? How should they be measured? What are the ways to achieve that? That this cannot happen without these kind of partnerships. So who do we value? What are we valuing? Whose perspectives are centered? The research literature, I mean, for as much as what all our presenters are talking about, pushing against Western literature, it is absolutely true. But the Western literature is not thrown out. It's critically evaluated and interrogated and then adapted, because it's not sufficient to meet the needs of communities. So instead of holding everyone to evidence-based practices that were never designed with communities in mind, what PARC and what all our research projects and associates are doing are lifting up practice-based evidence from community expertise in partnership with what the literatures and expertise of anthropologists, social workers, sociologists, psychologists, what everyone can bring. It's this partnership that can then elevate not just communities, but better the science. And this is also important, that this is about decolonizing research practices, challenging the assumptions that we make in our work, and then using it to inform the field. And this is really important work. So I again want to thank you all for what you're doing. And I know firsthand how transformative it is, just for everyone who participates. So with that, why don't we open it up to questions? And if you could, let's see, if you have questions, use a chat box or Q&A feature, and I will turn it over to Dr. Grills to moderate the questions, but I would encourage you, you have a few minutes. If anything was unclear, we also have a lot of acronyms in this work. It takes, just a few weeks just to get up to speed with all the language, but let's see. And Stephanie, we may ask for your help here. Are we going to be able to see questions from our audience?
Yeah, right now we can't see any. What impact on students have you seen? Oh, Michael Eng, how are you? Oh my gosh, wonderful, wonderful. I wish I could see you. What impact have I seen on students? Let me put it this way. I had a one-unit research course that I would offer, every semester for a couple of years. And this one semester, the students' research project, was helping out with collecting the surveys and actually figuring out how to improve the methodology. And at the end of the semester, they had to do a presentation of their findings to me, to our entire lab, and to the staff from the refresh spot. The students' presentation was so phenomenal, both in terms of the depth of content and analysis, but also they each shared how that community-based participatory research process impacted them, how many of the assumptions they had about what it means to be homeless and what are the characteristics of someone who's homeless were so leveled that it literally brought me to tears in class. I literally cried. Sandra, I believe you and Diane were there. I started crying because I was so moved by how it transformed them. And so I think the ability for students to get out into the field, to get their hands dirty, to challenge their assumptions, to learn skills and tools, to relate to people who have a life experience different from them is transformative. And they learn some skills that we then encourage them to put on their resume and in their applications for graduate school. Are there similar centers in other higher education institutions, or are we one of the first? I wish we were one of the first, but there are other institutions. I don't know the extent to which they integrate student involvement to the extent that we do, but I was just in a meeting last week with a epidemiologist at Johns Hopkins. And as we were talking, we're doing a COVID needs assessment nationally. He started asking about our center, and I was describing it, and I could see him, we were in a Zoom meeting, his mouth dropped open. He says, we're your sister institution, basically, over here at Johns Hopkins. And there are other centers kind of like that in different parts of the country. Again, I just don't necessarily know that they have the same level of student engagement. And then Jen also, I don't know if can they see our chat? Students from PARC have gone on to graduate school and practice in many different sectors. Basically, no one leaves PARC without a shift in perspective, and not just perspective, but heart as well. Absolutely. Yeah, we have a track record of about like 85 to 90% of the students that work with us end up getting into graduate school, and the postdocs that work with us end up getting tenure track faculty positions. And I think it's because they fill a niche that's missing out there. And then Sandra added it up. Sandra, you want to read what you said? You guys can speak up.
Yeah, sometimes we see our students come in and they want to do clinical work. They want to work individually with improving, mental health of individuals, and they leave going, I want to go into law, and I want to go into public health, and I want to go into sociology, and I want to go into community psychology. So it really does broaden their understanding of other social science disciplines and other career paths. So it's kind of remarkable to see that.
I just want to highlight how mission-based this work is too, talking about how you want to be with and for others in this kind of partnership. It's very consonant with the mission of a Jesuit institution. And I think among Jesuit institutions, this is quite distinctive. So it's a treasure at LMU.
Yes. So I believe we are at the witching hour. So we want to thank you all for taking the time to hear about PARC, which hopefully one day soon will shift from being the Psychology Applied Research Center to the People's Applied Research Center. Thank you to Diane, who came up with that code switch from psychology to people's. So thank you, everyone. and have a safe rest of your day and week.